for today's meeting as we have an ambitiously packed agenda today. Thank you so much for joining us online for this Nutrition for Growth side event on immunization, nutrition, service linkages, which is being co-organized by the London School of Hygiene and Tropical Medicine, Results UK, ALIMA, Nagasaki University, the International Rescue Committee, and the Every Breath Counts Coalition. I'm Leor Miller, the Director of Health Policy and Communication at the IRC, and I'm honored to moderate today's webinar, which brings attention to the critical connection between immunization and nutrition services. And I think we can all agree that, particularly in today's incredibly difficult funding environment, exploring innovative, integrated, and cost-effective approaches to children's health is more important than ever. So we have a distinguished panel of 7 speakers here with us today to share a wealth of research, program implementation, and policy and advocacy perspectives. Just a few housekeeping items before we begin. First, we welcome your questions and comments in the Q&A and chat function in Teams. So if you have a question for a specific speaker, please do indicate that. Our panelists will all be presenting in English with live transcription available, and we'll share a recording after the event. We'll hear from all of our speakers first and then leave time at the end for Q&A. So without further ado, I'm very pleased to hand over to our first speaker, Leith Greenslade of the Every Breath Counts Coalition for introductory remarks. Leith, over to you.
Thank you so much, Leor, and our co-hosts for having this conversation at Nutrition for Growth. So we're speaking today about an idea whose time has come, the integration of nutrition and vaccination services for children. What do we mean by nutrition services? Prevention, diagnosis, and treatment of malnutrition at the point of vaccination for all but the most severe cases. And what do we mean by vaccination services? Routine DTP, PCV, rotavirus, measles, and malaria shots for children in the first 2 years, and catch-up campaigns for older children. This is a smart strategy for child survival with over a decade of evidence to back it up. I want to take you back to 2010, when Nobel Prize winners Esther Duflo and Abhijit Banerjee published the results of a trial in rural India that gave food to one group of mothers for completing their children's vaccination schedules, a full 3 doses of DTP, and then compared vaccine coverage to the group that didn't get food supplements. Vaccine coverage increased dramatically from 6% to 40%, and they didn't even measure the nutritional impact of the food on the children and their families. So in the decade following, subsequent studies have only strengthened the evidence base, and global vaccine and nutrition agencies have started to take the issue seriously. But with 5 years left on the SDG clock and 4.8 million children dying each year, and remember, half of those deaths are related to malnutrition, we have to move faster. The coalition I lead, Every Breath Counts, has released a new campaign called No Vaccination Without Nutrition. And today, the Child Survival Action Movement has launched a call to action for vaccination and nutrition integration. And you'll hear about other important initiatives from the speakers on this webinar. We hope you will hear the evidence and become advocates for integration, not only because it's a smart strategy for child survival, but because in the current funding climate, it may also be an absolutely necessary one. Back to you, Leor.
Thank you so much, Leith, for sharing those really compelling remarks and setting the stage for us. So I'd now like to hand it over to our next panelist, Kevin Fellin of ALIMA, who'll be presenting on findings from the Nutravax trial, which is assessing SQLNS measles vaccination integration in Nigeria. So Kevin, over to you.
Hi, everybody. So I'm just trying to share my screen. Bear with me. And now, where is So yes, as Lior said, my name is Kevin Phelan, and I am the nutrition advisor for ALIMA, the Alliance for International Medical Action, and wanted to share a story of Nutravax, or integrating malnutrition prevention and childhood vaccinations. So first, I want to start with what is SQLNS. It is in the family of lipid-based nutrient supplements, which I think the most popular one is RUTF, ready-to-use therapeutic food, large quantity. And this is a small quantity. So whereas RUTF is 92 to 100 grams, the small quantity LNS, and it's designed for treatment, small quantity LNS is 20 grams per sachet. And it's meant to be added to the family meals, mixed in, and you take one sachet a day for anywhere between 6 and 12 months. And it has had a pretty remarkable spectrum of benefits, including reductions in mortality, iron deficiency anemia, severe wasting, severe stunting, and even developmental delay. There's really no other prevention intervention that carries with it such a spectrum of benefits. And it is in the WHO guideline for complementary feeding, and it is the only recommendation with a high certainty of evidence. Now, as evidence-based medical actors working primarily throughout the band of the Sahel, West, Central, and East Africa, we have always tried to integrate SQLNS into programming in high malnutrition burden zones for its impact and the evidence that it's shown on growth and development. And we want to prevent the large number of children coming into some of our malnutrition treatment centers. So to date, it's really been small scale. And anecdotally, we've always seen less severe malnutrition in the zones where we implement it. But interestingly, anytime we implemented SQLNS at small scale, 3 to 5 health zones, et cetera, we noticed that we weren't seeing any measles cases in those zones. And a couple of coverage surveys showed that in zones that were receiving it, measles coverage in particular was higher in zones that received it. So we, from that anecdote, decided we wanted to test a theory. And it is a theory that we call Nutravax. And we are all familiar with the vicious cycle of malnutrition and infectious disease. We feel that Nutravax can bring us towards a virtuous cycle in which SQLNS supplementation incentivizes, as Esther Duflo and Banerjee found with lentils, that it can incentivize vaccinations and vaccine uptake. So you will have a situation where you have less malnutrition and fewer infectious diseases. And here is a visualization of Nutravax. You see moms would come into the health center once a month to receive their ration of SQLNS. And at 6 months, you can perform catch-up vaccinations on children, especially those with 0 dose. And now the newly introduced malaria vaccine with doses at 6, 7, and 8 months, and then measles 1 at 9 months and yellow fever, and then measles 2 and rubella where it's called for at 15 months. And all the while you're getting the benefits of the SQLNS on growth. And so where are we testing this? Our first pragmatic parallel cluster randomized control trial is going on right now in Yobe State, financed by Eleanor Cook Foundation and Gavi. And a word about research in humanitarian settings or development settings, it is not possible without building alliances. And we have alliance, and that has mobilized European and American and African researchers to provide the best evidence, the best level of quality of evidence, because these questions deserve that. And part of CORAL is formed by the Global Health in the Global South initiative at the University of Bordeaux, with INSERM, with PAXI, and in the case of Nutravax, our first trial with doctors and researchers at the Yobe State Teaching Hospital. So Yobe is in northeast Nigeria, and northeast Nigeria is a setting, a context with very well-known high rates of malnutrition and low coverage rates for vaccinations, in particular measles. And here you see in Nguru and Karasua local government areas, basically that's what they're called, they call districts in Nigeria, local government areas, LGAs. We have very high SAM, nearly 15% GAM, 3.7% SAM, and low measles coverage at 60%, card or by recall. Card alone is only 30%. So the main objective of this study is to estimate the effectiveness of SQLNS, mass supplementation program, on routine immunization uptake versus control zone, which is going to be just routine immunization alone. And the study population will be children aged 12 to 23 months, and for the cross-sectional household surveys, and 6 to 12 months at inclusion for our longitudinal survey. And the secondary objectives include additional vaccines, timeliness of vaccine, vaccine catch-up reductions or not in zero-dose children, etc. The design of this parallel cluster randomized control trial is to, it's going to be different populations and different data collection modes. The first is going to be our baseline and endline cross-sectional household surveys of children aged 12 to 23 months. The second is a longitudinal follow-up survey of children 6 to 12 months at inclusion. We're also doing some qualitative work that included both an interim qualitative feasibility survey and we'll have an endline qualitative survey as well, and cost effectiveness work that is being performed by Professor Katie Adams at University of California, Davis. Here is just a visualization of the intervention. In the standard arm, you have community mobilizers promoting vaccine schedules, as well as promoting IYCF. And then in the Nutravax arms, you have the same, but you also have community mobilizers educating on SQLNS and determining age eligibility for inclusion, etc. And you see here, the mom comes to the health center in Nigeria. It's called a PHCC. And they're in the waiting room receiving sensitization. You can even add family MUAC in the triage area. And then in the control zone, they check their vaccine status and update as called for. And then in the Nutravax arm, you have a step at the end of the process where you distribute the ration of SQLNS to children after confirming vaccination status. Progress to date. So interventions in both arms began July 2024. The baseline coverage survey, the final analysis is complete, and we saw levels of measles vaccine coverage in our survey a little lower than was found in the DHS or the mix survey that I had on a previous slide. The longitudinal survey is 4 total visits, home visits, over the course of the study. There are 600 children enrolled, 300 in each arm. And our third visit is currently ongoing, and the fourth and final visit will take place in July. The interim qualitative survey has been finished, and the analysis has also been finalized, and we're adapting our program based on some of the findings. And the cost analysis data collection actually has now finished, and we will start analyzing those results soon. And we just held a national advisory committee in which stakeholders in the nutrition and vaccine communities, both at the local, the state, and the federal level, which we are convening every 6 to 9 months in order to keep those stakeholders engaged and aware of the progress of the study. And so some results that I can share, the SQMS distributions did begin in July. To date, we've enrolled more than 13,000 kids in the Nutravax arm in SQLNS distribution. I want to draw your attention to the defaulters. There has been a total of 5, that's not 5%, but 5 defaulters from the SQLNS distribution, which is a very good indication about how valued SQLNS is to families, some who need to cover their own transport to get to the health center. Next steps between February and December, we're going to be continuing the awareness raising efforts in both arms of the study. End-line cross-sectional survey will be coming up in May, June. The final home visit will be June, July. The qualitative survey, the final survey will also be June, July. It's going to be a busy summer. And then cost analysis survey and analysis will be ongoing. And we will be closing out the study in August 2025. And by that, we'll be developing both a dissemination plan for the results, probably by the end of the year, and transitioning SQLNS distribution and advocating for SQLNS distribution in Karasua and Nguru LGAs with the MOH and other partners in Yobe State. Here is the absolutely stunningly amazing team in Yobe that is carrying out and dealing with all of the day-to-day headaches that come with running an SQLNS program, as well as a high-quality trial in trying circumstances. So I really give any credit for the quality of this study is going to go to them. And then finally, this notion of using and testing whether or not SQLNS can be an incentive has been appealing to people. And the Bill and Melinda Gates Foundation, as well as Adhesia, have invested in a 2-year project, adding SQLNS to districts that are using Optima treatment protocol in both Nguri, Chad, and in Miria, Niger. And SQLNS distributions there hope to begin in April, May, and London School of Hygiene and Tropical Medicine will be performing some qualitative work as well as some cost modeling. So I want to thank everybody for your attention, and now I will stop sharing and look forward to any questions you may have at the end. Back to you.
Thanks so much, Kevin, for sharing this really exciting update on the progress of the Nutravax study. And I think we can all agree these findings will be crucial to strengthen the evidence base for integration and, watched closely with bated breath. Our next speaker is Marco Karak of LSHTM, who will be presenting on opportunities for integrating immunization and nutrition within NAMI. So Marco, over to you.
Great, thank you very much, and hope you can hear me okay. My name's Marco Karak, and I'm a clinical associate professor at the London School of Hygiene and Tropical Medicine. Oh, hang on, let me just, it is on. So I'll be sharing on the MAMI RISE randomized trial, which wasn't designed initially as an example of nutrition immunization overlap, but has very much become an exemplar project demonstrating the value and the benefits of the overlap and of a very strong link between the two services. So the MAMI vision is that every small nutritionally at-risk infant under 6 months and their mother is supported to survive and thrive. And to help you understand what MAMI is, I want to start off with a little story, a summary. And this is based on some real-life experiences which we've collected over qualitative work, both in Bangladesh, where one of the earlier projects was, and more recently in Ethiopia. We were so happy to have twins, but pain after my cesarean meant I didn't breastfeed well. I had to top up with formula milk. So expensive, even for one baby. My husband became angry for the cost, and I was scared. Then the babies became ill and very thin, but the hospital was too far away. My daughter died, aged 2 months. When I took my son to the immunization clinic, and again, this is the key, the nurse weighed him and on the basis of that recommended Mammy. She encouraged and helped me to breastfeed, and it was amazing. He grew strong and in 2 weeks stopped needing formula. Now we're proud parents of a healthy, happy little boy. I often wonder though, if I'd had Mammy earlier, might my daughter also still be alive? So the problem underlying Mammy and why we're doing this, I think everybody's familiar with, it's a high burden of malnutrition, but in particular, very high burden in this infant under 6 month age group. And the reasons for tackling this are survive, thrive, and transform. And it's not just those short-term benefits on mortality, morbidity that really matter. It's also the long-term implications and increasing evidence that we're seeing in some of our other related work that treating early life malnutrition also has big impacts on long-term chronic disease for the survivors of early life adversity. And towards this, our Mammy solution is, and we have a core product, but really important to emphasize, it's not just this product alone. We also engage with fathers, families, we address social issues, we look at child development, we look at early planning for complementary feeding. But our core product has a benefit for infants, so it supports the immune function, affects the microbiome, it has benefits for mothers, so it's highly cost effective, has a role in maternal health, and also has important social benefits. So it is, of course, breastfeeding, which, if it were discovered and marketed as a pharma product, would be hugely, hugely profitable. But sadly, in the world, doesn't have nearly the support it needs in so many settings. So this is our core product in Mammy, but it's supporting and looking at wider issues as well to help mothers feed. The second problem we're addressing is poor integration and lost opportunities to intervene. So we know that both antenatally, but even postnatally, there are many, many contact points. And we've been certainly realizing that the EPI, the immunization contact points, are plentiful in this under 6 month age group. So we have contact points in the first week of life, at 6 weeks, 10 weeks, 14 weeks. So lots of contact points. But sadly, even if children are measured, that weight is often not translated into an interpretable weight for age, interpretable measure, and very little is done. So what we're trying to do as Mammy is open people's eyes, actively look for weight, nutrition growth at the immunization visits and act on it. So how the program works is at the immunization visits, but actually at any community contact point, we have a rapid screening. Then from that, about 10 to 20% of infants will require a full assessment. And from there, some may be fine, so they don't need any particular care. They just go back to routine treatment. Some will be sick and very vulnerable, have complicated malnutrition. They'll need inpatient care, but the majority can have Mammy outpatient care. And what that involves, and of course, they can move between the different parts. So it's not just a one-off screening, but the beauty of linking with immunizations is it's repeated screening as they come back for their subsequent immunizations, because it's very possible, and it happens, that they may be fine at the first, second, even third visit, and only then later develop problems. So it's that repeated visit that really matters. And so what the Mammy Care Pathway does is it essentially empowers healthcare workers. So this was me when I qualified as a junior doctor, but we had the benefit of long years of training, extensive supervision, and I think above all, I really realized that having the basic training is only part of the package, because when the first infant arrives, then suddenly things become very different. So you may have the basic training, but the first infant completely changes that. And what the care pathway does, it provides user guides to support the healthcare worker. It provides forms, so a checklist to help support them and remind them the key questions to ask, the key things to do. And it also provides counselling cards and support actions. So for the many different problems that can underlie infant malnutrition, provides actions as to what to do. So by equipping the healthcare workers and making the healthcare workers more empowered, more able, more on top of things, it benefits the infants, and in turn benefits the mothers, the fathers, and the wider family. So that's essentially what it does. It's a step-by-step structured guide, a clinical care pathway. And it's made possible by identifying infants at immunization visits. So that was really key. So we finished recruiting last year into a large trial of 2,000 infants in Ethiopia. So we're just in the process of writing up, so I can't share the detailed results, but what I can say is we've got a very strong impact on breastfeeding, we've got a mixed impact on growth and anthropometry, and we have a strong impact on infant development. And you can see the details here if interested later. And I just want to highlight the benefits of that. So looking at that nutritional benefit, which we get by having a platform in the immunization visits, breastfeeding has a huge difference, a huge impact. And just theoretically taking a change from 22%, which could be what we had in our control group, to if we increase that to exclusive breastfeeding rate of 65%, then that has massive impact on fewer diarrhea cases per year, has an impact on almost 4 million fewer IQ points lost. That could have an economic benefit of over $800 million. So just supporting breastfeeding has a huge impact, and that's made possible by entering the program through the immunization visits. I want to highlight some other interesting results. So these are just our baseline. And one of the things that we've been really thinking about and asking ourselves as we've been crunching some of the results are, so does this integrated service actually make things more attractive and engaging? Because what's interesting is that our baselines are actually quite imbalanced. So in our intervention group, we actually have fewer exclusively breastfeeding when they enrolled. So over 10 percentage points fewer than in the control group. Infants in the intervention group are also smaller at baseline, and the mothers are also more stressed, have higher mental health needs. So we can't prove this definitively, but qualitative data, it could just be chance, but qualitative data certainly backs our hypothesis that the integrated nature of the MAMI intervention, so in particular that link with immunization with health clinics, attracts those who'd otherwise stay at home. So the reason why we're seeing smaller, more vulnerable infants is that in other settings, parents know very well that infants are vulnerable and they just don't engage. But because now there's a reason to engage, it's not just coming for immunization, it's coming for a wider package of care. They come rather than staying at home, so it's more engaging. It's a much more efficient use of time for healthcare staff, for carers. It's valued. And it does, because it's more engaging, it especially engages those who are the most vulnerable. I want to end with 3 messages. So MAMI is a product, so it's breast milk, but the other components as well. And it's a pathway, and it comes in a package, and it builds bridges between nutrition, immunization, but also child health, maternal mental health, social care, and child development. But that nutrition immunization linkage is certainly key to getting off on a good platform. We have important preliminary positive results. And thirdly, our message is that integration with immunization is key. And it seems to be helping attract the most vulnerable mothers and infants. And we see it as a pathway to greater equity, efficiency, impact, and future scale. So big thanks. You can find out more about MAMI here, and hopefully we'll be releasing our results very soon to find out more. Thank you very much.
Thanks so much, Marco, for sharing those insights and really how MAMI is comprehensively providing and addressing the needs of infants, mothers, and then those wider societal impacts that you mentioned. I'm now pleased to hand over the floor to my fellow colleagues from the IRC, Peter Mutunda, who will be presenting on program implementation experiences from the Gavi Reach project, and Claire Eldred, who will be presenting on the CMAM Avancé project. Peter, the floor is yours.
Thank you very much, Leo. Good evening, good morning, good afternoon, everyone. So I'll just make this into presentation mode. Is that okay, Leo?
Looks good.
Great, thanks. So so we'll do this with my colleague Claire, who will come in after my presentation. So we want to look at On the side of implementation, what we are witnessing, what we are experiencing, and what lessons we can get from this. So the outline is we are presenting 2 case studies, one from the Gavi Reach project being implemented across regions of Africa, and then my colleague Claire will speak to another area of programming within IRC. So just maybe to give a brief outline about the project that I'm part of, which is the Gavi Supported Reach program. We are into the 3rd year of implementation, started way back in 2022. The main aim was to ensure that vaccination activities or programs are implemented in some of the hard-to-reach communities, conflict-affiliated zones, fragile societies, coming out of conflict, wars, natural situations. Initially, we had a complement of 4 countries that includes Ethiopia, Somalia, South Sudan, and Sudan. But late last year, we had an addition of 2 other countries, that was Chad and Nigeria. So the whole scope is to ensure that we reach the children with a full immunization complement as per the guidance from the national immunization programs and guidelines. So we have targets of about 1.8 million children in close to 167 jurisdictions across the countries that we operate in. So just some results from the implementation side is that we're combining decades of experience from IRC programming in some of the humanitarian settings across the region, the health expertise that we get from some of these countries, and also we optimize the collaboration of the national partners that we work with closely. So in every country that we operate in the 6 countries, we have quite a few national organizations that really complement the services in terms of reaching some of the areas that will be a bit of a challenge to IRC operations. So if you look at the data at the end of January 2025, we had close to more than 1 million children having received the first vaccines from the project support. And about 40% of this will be older children, 12 months and above, up to 5 years. We had close to 400,000 DPT doses delivered to the children between 1 and 5 years, and also about close to 1 million of measles vaccines given to children between 0 to 5 years across the period of implementation up to January 2025. So maybe just to highlight one key element here is that the areas that we initially were targeted at the beginning of the project, we didn't have full access to all the 167 districts at the same time. So it had to deal with a lot of negotiations for access in some of the most difficult situations where the national programs will not have reached for sometimes years before. It called for some innovations around last mile vaccine delivery. It called for some difficult adaptations in terms of what kind of options of vaccine delivery that would offer in some of these regions that would benefit from the operations. So why integrate? So essentially, I think from the experience is such that it's extremely difficult to offer an immunization program on its own to situations where you have multiple public health situations, malnutrition, basic essential health services not being available, and other social services not just being delivered by the mainstream authorities. So again, you're responding to the preferences of the caregivers and the communities, societies that we want to offer more than just one service whenever you're providing these kind of public health interventions. So just about optimizing what you can give in picking a family as a unit. What else do they need at that particular moment when you are reaching them in a unique way, when they will not have had maybe an opportunity to receive similar services for a longer duration of time past the normal routine that will be provided in stable situations. And we've seen quite very good results in terms of the uptake. It calls that whenever you're mobilizing activities, immunization, including other services, you have, especially for the nutrition services, you have more communities coming along, bringing in their children. And for the fact that we are targeting some of the older children who are traditionally, 1, 2-year-old. I mean, society has never had the behavior of taking their children for vaccination above 1 year, which is not a very easy behavior to change. But I think it works best when you have some elements of support that will go alongside what the community will require at the same time. So different, we talk about integration whenever we are, designing or planning, but the realities can be very, very different, because sometimes for such a project like REACH, some of the programs that we are integrating with are not directly in line with the REACH timelines. They may not be in line with a particular area of implementation. So it calls for a bit of negotiations with some of the implementers in the communities and in the areas where we work in. This could be national operations, the national agencies, and also sometimes other international agencies that work alongside. So it could be a complement of many other services. So there's no particular package that is uniformly provided in a particular or prescribed in a particular region. So you may have nutrition, which is the largest complement of integration that we've seen across our areas of operations. But there are also others, health timing and spacing of children, family planning, WASH activities, other early childhood development programs, and also the whole maternal and child health services in the community. So we've seen quite very good integrations in some of the services that we provide and communities that we serve around outpatient therapeutic programs running alongside immunization activities supported by Gavi REACH project, supplementary feeding programs, and also quite a bit of screening at community level using the same service providers or community health providers that will provide mobilization and demand creation activities in the community. So maybe just to highlight one area that has been quite demonstrative of our support and also how integration has worked well is the Ethiopia country program, which is the largest portfolio in the Gavi REACH programming with IRC, with close to 47% of all the service outputs in 2024 are coming from Ethiopia. About 400 sites that are targeted for implementation with many more outreach posts in different and 6 regions of the country. And we were able to map out consistent supplementation of immunization activities with other nutrition programming in about 37 of these REACH supported sites. And out of these, about 34%, 117, will be providing supplementary feeding alongside immunization in a consistent way. So, but besides that, almost all the sites that we work in have multiple nutrition demands and also needs. So they will routinely be offering screening, nutrition screening services alongside other public health demand, prevention activities in the communities. In one particular area in Oromia, we were able to witness, just from the records from the service registries, that about 40% of children who had just been immunized in the quarter that we were looking at the data had received immunization, but were also either moderately or mildly malnourished. The sorry state is that at that particular moment, there was no much nutrition support going on. They were all waiting for some implementation partner to resume services because of the conflict that was going on at that particular moment. So just a picture there demonstrating some of the activities in one of our areas of operations in Tigray, in Ethiopia, showing a brave child receiving the shot of vaccine from a not very brave caregiver, as you can see. So let me invite Claire to proceed to the next phase of the presentation. Thank you.
Thank you, Peter, and hello, everyone. As mentioned, my name is Claire Eldred. I am the Monitoring and Evaluation Advisor for the CMOM Avancé project at IRC. And I'm going to walk you kind of through the reverse scenario where we have a nutrition treatment program where we've implemented vaccinations. Next slide, please. The CMOM Avancé project is funded by GiveWell. It was originally a 3-year project, but has since been extended, and we're currently in the 4th year of implementation. We provide SAM treatment in Chad, Burkina Faso, Niger, and DRC, and MAM and SAM treatment in Somalia. The overall objective of the project is to demonstrate cost effectiveness of malnutrition treatment that can be replicated and scaled up. This project has enabled us to innovate, test, and scale up various approaches that improve treatment coverage with the goal of increasing coverage year after year. We also want to increase access to high-quality malnutrition care that is integrated into the national health systems, and also to strengthen technical expertise of health and nutrition providers. Next slide, please. So where do immunizations come in? We decided to integrate immunizations into our treatment services in order to boost malnutrition treatment coverage by pairing it with immunizations, increase cost efficiency by leveraging existing service platforms, and of course, hopefully improve health outcomes. The integration models included in advanced vaccination strategies for rural underserved areas, and vaccinations are available for all children, regardless of their enrollment in malnutrition treatment. So we give BCG, OPV, Henta, measles, etc., to both malnourished and not malnourished children. The model also varies from country to country, so which immunizations are offered may vary, but what other treatments, for example, deworming pills in some countries, but all countries using this strategy also use malnutrition screening and treatment. So to give the example for one of our country programs, which is Somalia, we use mobile clinics to provide these integrated services to children that may not have been vaccinated otherwise due to distance or availability of services more broadly. So the team looks at the child's health card to see if their vaccinations are up to date and vaccinates those with incomplete vaccinations. This recaptures otherwise under-immunized or unimmunized children. The children are also screened for malnutrition and admitted for treatment if found to be SAM or MAM. The mobile team then returns to that same site every 2 weeks for follow-up treatment visits and continued screening and immunizations. There are several benefits to this approach that we have noted, including it brings more children to be screened for malnutrition because more services are provided. It also brings this treatment closer to the community. This in turn increases nutrition and service and immunization coverage, and we believe it improves the health outcomes for children. It is also cheaper and more cost-effective because instead of sending a separate mobile clinic out to provide only nutrition services or only immunization services, it's possible to provide both of these services with minimal additional cost. So in Somalia's case, I believe we only pay one additional health worker on the team for immunization specifically. In year 3 of the project, we were able to vaccinate at least 34,000, give at least 34,000 vaccine doses, and we treated more than 7,500 children for SAM and MAM via these mobile clinics. A similar approach is used in other CMOM Avancé countries, but vary according to the national protocol, the health system, and other social or contextual factors. So similar program, but might vary according to what the local context is needing. Next slide, please. Through both IRC program implementation experiences across REACH and CMOM Avancé projects, we've obviously experienced challenges and seen many areas of opportunities for enhancing scaling and integration. Some challenges to note include a need for better data tracking and integration across sectors. As a meal person, I'm probably a little biased there. The absence of nutrition services despite high levels of severe malnutrition in some settings. Vertical programming and funding mechanisms are always a challenge, and then limited resources and funding in fragile settings. And of course, there's always the challenges of logistics and supply chain constraints. A few key opportunities we wanted to highlight are that we think we can capitalize on high immunization program coverage to reach more children with malnutrition treatment and other nutrition treatment services. We'd like to strengthen partnerships with health and humanitarian actors, expanding mobile outreach strategies, and leveraging community engagement for demand creation. And then shifting donor mechanisms to foster integrated programming would also be a great opportunity. And next slide, please, and back over to you, Peter.
Thank you so much. Just to finish off this presentation is just to look at some of the lessons that we've learned across the implementation is that, I mean, we plan for integration during the proposal and sometimes the design stage, but things can be completely different because sometimes you think you're aligning your programs to another existing program. It takes 1 year for a proposal to go through, a project to be approved, then you go to the ground and find something completely different. So I think it's important that as much as you're planning for integration, the proposal and the design phase of any programming, you also may want to look at it at the initial phase of it so that it becomes more aligned. So I think we had quite a bit from the previous speakers about the cost effectiveness of some of these results. And I think as much as we know that they are effective and useful, sometimes the ministries and the authorities will want to see the data that supports these drivers of what could be more useful whenever integration happens. So again, we don't measure integration so much because as much as we know it happens, and I think sometimes the after fact measurement, trying to look what happened. But I think we need to design the measurements around what could be, some of the processes and outputs that would come out of implementation whenever we talk about integration. Thank you so much, and back to you, Leo.
Thanks so much, Peter and Claire, for those two very interesting and practical examples of integration in action and some of the lessons distilled. I'd now like to hand things over to Seokyoung Lee of LSHTM, who will be presenting on early findings from a systematic review on immunization nutrition integration.
Thank you, Lear. Hi, my name is Seokyoung Lee. Today I'll present the early finding of the systematic review I've been conducting on integration of nutrition and immunization. So I put the two logo here because I'm on a joint PhD program between London School of Hygiene and Tropical Medicine and Nagasaki University. So why am I conducting this systematic review? It's a method that show the highest level of scientific evidence. So you can see on the right side, there's a diagram that shows that systematic review is at the top of the evidence hierarchy. So it systematically screen all the relevant studies published. And it's a fair, unbiased method that include both positive and negative studies, also including the adverse effect and challenges. So we can learn the lesson from, and it also complement the previous evidence. So I'll just briefly go through the process of systematic review. So what I have done is I have created the synonym, the search term that include immunization and nutrition interventions. And I have included all the search term, and I have combined the list, the two lists using AND, and I have applied this search term on the 5 major database. So my inclusion criteria were children under 5 years, and I've included all the intervention that combine somehow nutrition and immunization activities. So outcomes include any anthropometric measurement, feeding-related outcomes, knowledge practice. Also, immunization outcome include coverage. So the 2-stage screening process applied. The first stage screening, we're only looking at the title and abstract review. So each article were reviewed by at least 2 reviewers, and the tool confidence was used. And initially, there were more than 10,000 articles found. So among these, the first stage, we're only looking at the title and abstract review, and the second stage, we're looking at the full text review, and it's ongoing. So I'd like to just highlight a few key papers that I found from this review process. I have selected these papers as there are some lessons learned that I want to share with you. So the first paper were from Pakistan. It looked at over 4,000 children in conflict areas. So interventions were integrated model of maternal, newborn, child health, and immunization and nutrition services delivered by community mobilization and mobile outreach. And the control groups didn't really receive the same interventions. There was an improvement shown in fully immunization children. So it increased from 27 to 51% in the intervention groups, comparing baseline and endline. There was also a decrease in the number of zero-dose children and children who have missed a specific vaccine doses. So from this study, what I want to highlight is combining these two interventions worked. It shows some positive impact in the vaccination coverage, but this study doesn't report the nutrition outcome. So for us to see both side impact, it'll be important to include both the outcome result for the future programs. So the next study is from Mexico. It looked at 80 mothers with infant under 4 months of age, and the breastfeeding counseling were provided using the socio-ecological framework for intervention groups. So it's interpersonal counseling, including all individual factor, group factors, and social factors. So in contrast, the control group only received the standard counseling and immunization and infant feeding information. As you can see, there has been some improvement in exclusive breastfeeding rate in the intervention group by 30% at 2-month follow-up. In contrast, the control group only had a 15% decrease in the exclusive breastfeeding. And there was also improvement in the breastfeeding attitude to self-efficacy. What I want to highlight is, at first glance, it looks like the integration didn't work because the control group that had both components were actually having not as great result as the intervention group that only had looked at the breastfeeding counseling delivered. But this is an important study because it reminds us that integrating itself is not enough. It's an active process. So program managers and policy makers have to also look at the both part of equation, that it has to be very quality activity delivered in both end, because standard counseling is often not optimizing the information delivery. So it includes minimal information that are not really targeted for specific obstacle or individual issues. So next paper is from India. So it looked at included over 1,000 caregivers of children under 2 years of age, and it intervention group received nutrition counseling on breastfeeding, immunization, and it was all delivered using multiple channels. And the control group didn't really receive the counseling intervention. So you can see that there was an improvement in the exclusive breastfeeding prevalence when the counseling were delivered through multiple channels. And the immunization session was the most common source of information where the caregiver received the counseling from. So what I want to highlight here is that combined interventions are effective in improving the key nutrition indicator, but programmers and policymakers need to also be mindful of timing and immunization visits, because the young infants have more frequent visits than the old infants. So older infants need to have probably other solution, not just the integrating the nutrition and immunization strategy. As they get older, they will have less frequent visit to the immunization clinics. So in summary, I have put some key take-home messages here. So early evidence shows that the integration works. It's effective and useful, but each intervention from both sides should be very proactive and effective, not just delivering the information to the people, but it has to be more interactive, interpersonal delivery of services. So the future research should also look at the both sides, because we're interested to know whether there are any improvement in both sides or whether there's only improvement in one side, not the other. The last one I want to highlight is that immunizations visits are more frequent for the younger kids, so it may be more or less useful to combine nutrition intervention with the immunization programs, as it matches the immunization schedule. So we have to really mindful of at different ages when delivering the nutrition and immunization intervention combined. Thank you.
Thanks so much, Seok-young, for those initial findings, and we'll really look forward to seeing the final results of that systematic review you're leading. Last but certainly not least, I'd like to invite our final speaker, Alex Brunswick of Results UK, who will be making the advocacy case for integration. Alex, over to you.
Hi, everyone. We're obviously taking a slightly different tack with this final talk because I'm not a researcher. I'm not somebody who has experience of delivering programs in country. My role is to go and talk to governments like the UK and to persuade them to fund integrated programs. Well, to fund development in general, but specifically in this case, to fund integrated programs like immunisation and nutrition integration. So I'm Alex Brunswick, Head of Policy Advocacy at Results UK, and I'm going to tell you a little bit about why this is important for us at Results UK, but also what I think it is we need from governments to be able to make meaningful progress on integration, and what we can all do as advocates for people who want more money to be spent on development, who want money to be spent on integrated programming, what we can all do to make that happen. So there are three very broad reasons why Results UK is so passionate about integration and excited to be taking part in events like these. The first is who we are as an organisation. The second is the type of innovative, flexible and community-led development that integration represents. And thirdly, and arguably most importantly, it's an approach that we believe can persuade countries like the UK to fund and to help them deliver their own policy priorities. So who is Results UK? We're a UK-based advocacy organisation that exists to end poverty. At a top level, we see that there are three key elements we all need to get out of poverty: health, education, and economic opportunity. Improving access to any one of these three areas is a good thing in its own right, but ending poverty requires all three. So we are always looking for examples of ways to demonstrate that the links and impacts between integrating different policy areas. We published an advocacy report on the importance of I&I earlier this year, and this week we've also launched the second in our series of good news briefings, good news on nutrition briefings, and this one is specifically on integration. The first one was on prenatal multiple micronutrient supplementation and breastfeeding support, and the third one will be on ready-to-use therapeutic food and nutrition-sensitive food systems. But specifically, this briefing highlights an I&I programme in Uganda and an integrated homegrown school feeding programme in Nigeria, demonstrating what integration in nutrition can look like beyond just vaccinations and also beyond the first 1,000 days of a child's life. These briefings are very much focused on recognising how far behind we are when it comes to ending malnutrition, but also drawing attention to successful examples of programmes that can make a big difference despite these difficult circumstances. And for us, I&I is very much an example of that. Another reason why we're so passionate about integration is what we call within Results citizen voice, but what could also be described as a human rights-based approach, which is fundamental to how we see international development. I want to highlight how important it is that these approaches are community-shaped and led. You can have I&I programs run in different parts of the same country or in different programs that look quite different, but deliver the same outcomes and the same good results. We believe that this is morally and ethically the right thing to do, but it's also really important from an advocacy perspective. This is a key argument we can use with donors. So, as you all know, at the moment, spending on ODA, on development in the UK, has recently been cut yet again, this time to 0.3% of GNI, down from the legal obligation of 0.7%. Whilst we are, of course, campaigning against these cuts, we also have to recognise the reality of where we are. And as advocates who want to increase spending on nutrition, we have to make sure that we can demonstrate impact, cost effectiveness, sustainability, and that we can help to deliver national policy priorities such as improving outcomes for women and girls. I&I is a really good example of how we can do that. While investment will be necessary to ensure integrated planning and upskill community healthcare workers, integrating services can reduce duplication, optimise resources, and lower overall healthcare costs, for example, by optimising the supply chain and reducing logistics costs. In regions where health systems are fragmented due to instability, integrating services provides a practical and effective solution. By combining nutrition and immunisation, communities living in fragile settings would benefit from fewer visits, more coordinated health campaigns, and potentially safer, more consistent service delivery. Integrated services can also reduce the caregiving burden on women while improving the health of mothers and adolescent girls. Addressing malnutrition in women and girls is essential, and it has significant intergenerational impacts. These are 3 areas that we know are priorities for the UK government, and that's why I'm specifically highlighting them in this talk about integration today, because integration is a very good thing in its own right, but it can only happen if we persuade governments like the UK to fund both the research that proves how effective it is, but also to fund the programmes to make this a reality. We know that the UK government is not making a financial pledge at Nutrition for Growth Summit this year. And while this is obviously disappointing, it's worth noting that they have launched a policy initiative on integrating nutrition more broadly into development programming. It's called the Global Compact on Nutrition Integration, and it's open for all stakeholders to make a commitment. The idea behind the commitment is that we can all say what we will do to integrate nutrition into broader programming and how we will help to scale up work on malnutrition. So there are advocacy opportunities for us to prioritise nutrition, even in the current constrained fiscal environment. For Results UK, our commitment as part of the compact will be to develop work on the importance of nutrition to preventing the transmission of tuberculosis among close contacts of TB patients. There's an amazing case study from India about how effective that can be. So what are our asks of the UK government? What support can they and other governments provide to make sure that integrated programming becomes a reality in all of the areas that it needs to? So the first, obviously, is that they can provide financial support for integrated nutrition and immunisation programmes. We advocate for the UK government to give funding to support global health programmes that integrate nutrition and immunisation services with a focus on low and middle income countries. We also make sure that we hold the UK to account for commitments that they make to global health programmes. The second thing that we ask the UK government does is build the evidence base and utilise the outcomes of that evidence. So specifically, we want them to promote and fund research into I&I by supporting pilot programmes, to celebrate the successful new models of development funding and partnership working embodied in I&I, and to use the evidence generated to scale up successful models and expedite integration efforts. And the third ask we have of the UK government is to contribute to the successful resourcing of key partners. So as many of you will know, 2025 is a very big year for different global health replenishments. Gavi, the Vaccine Alliance, is one of those multilateral partners that is currently going through a replenishment process, and it is now holding its conference in June. But one of the things we do as an organisation is that we advocate for increased UK contributions to international partners like Gavi, who can support the collaboration and integration of nutrition and immunisation efforts that is critical to I&I being able to happen. The UK is one of Gavi's original donors, and it's currently the largest sovereign donor to Gavi's core programmes. And Gavi is one of the most successful development initiatives in history, so we're very much hoping that the UK and other donors will come forward and will fund their new strategy, which is called 6.0. The final point I wanted to make is that the other thing that's really important about integration from an advocacy perspective is holding governments to account, whether that's for a financial pledge that they've made or a commitment to an approach like integration. We have to make sure that integration in practice is the same kind of high quality programming that you have heard about from all of the speakers today, where there is a lot of investment in training community healthcare workers and ensuring that people on the ground get the help and support that they need and that deliver really high quality outcomes. What we don't want to happen is for integration to become a buzzword that is effectively used as a euphemism for cost cutting. I'm not suggesting that anyone has bad intentions, but like many people who have been involved in advocacy for a long period of time, I have seen a number of programs where language and concepts have been co-opted and not led to the change that is so urgently needed. So my call to everybody on this call today is to think about how you can advocate to your own government to support I&I and to support integration in nutrition programming. Thank you.
Thanks so much, Alex, for those really inspiring remarks, highlighting the advocacy efforts you're leading and other opportunities for advocacy. And thank you to all of today's speakers. I think they all deserve a virtual round of applause. We will now turn over to Q&A and aim to get to as many questions as possible in our time remaining. So I think we now have allowed any one of our participants to raise their hand and quickly ask a question of one of our speakers, and then someone will answer. So Dr. Aditya, I see you have raised your hand. Over to you.
Hello, Professor. I'm Dr. Aditya. I hope my voice is audible.
Yes.
Yeah. My question is very simple, Professor. My question is that since we have this integrated program, since we come from the rural India, we have this finance deprived packages where we wanted to give the exemplary treatment, but we are financially get locked. So how can we break these locks, like in an integrated management? What are your practical experiences and with which I can do more better in the rural India? That is my expert question. Thank you.
Great. Thanks so much for that question. Maybe I'll go back to our very first speaker, Liz, and then any other speaker who wants to jump in after her.
So I think Dr. Aditya has hit the nail right on the head. You can integrate policies as much as you like, but if you don't integrate the financing, you can forget about it. So at the moment, we have a system that finances vaccination through Gavi, very organized, very coordinated, and it reaches the poorest countries. We do not have an organized system for financing nutrition. It's very fragmented, it's very small amounts of money, and it's all under threat. So that's why we're calling for Gavi to also provide financing for nutrition so you can properly integrate the two services so countries don't find themselves with money for vaccines but then scrambling for money to pay for the nutrition side of it. We really have to take that giant step forward and integrate the funding of these two, they've been separated, services, vaccination and nutrition. So that's what we're calling on Gavi to do. And further, we're saying in the current environment, we're actually in a huge crisis. Global health is in a huge funding crisis. Donors are pulling back. They're looking for opportunities to bundle their commitments and to achieve efficiencies. And we think this is a great example of how to bundle funding that donors typically separate, save on overheads and supply chains, and deliver more for the same amount.
Thank you so much, Professor. Thank you.
I'm not a professor, Aditya, but thanks.
I'm sorry. I'm sorry. Exactly. Thank you. Thank you.
Great. Any other hands, questions? So one question that might be percolating and burning on everyone's mind is, what do the current global health funding cuts mean for this integration agenda? What do we think? Is it too soon to tell? Do we have any inklings? Maybe I will invite Alex to give a first response, and then any other of our speakers.
I think the first thing that I would say is obviously the cuts are devastating. Any cuts to international development programming can cost lives, and cuts at this scale are incredibly serious. So I don't want anything I'm about to say to be taken as in any way minimizing what I know is a really damaging impact that those cuts are happening at the moment. I do also think, in addition to that, though, that integration is an easier argument to make than some traditional development funding because, as Leith's already been saying, it bundles things together. It's possible that with integrated programming, it's possible that you get both better outcomes for the individuals concerned and you can save money, which is obviously a win-win for everybody. So I do think that there are absolutely important advocacy opportunities for us at the moment to get more funding for this kind of integrated programming. But that is not to say that we don't also need to be fighting back against the cuts, and we don't also need to recognise the devastation that those cuts are causing.
Thanks. Any of our presenters want to jump in to add to that?
I think it
Go ahead,
it just
Kevin.
caused like unnecessary destabilization, and I think we're all trying to manage it as best we can. Certain programs will start closing, certain areas will start to suffer, but I think it is a little too early right now to find out.
Thanks for that. And we have a question from Kaja Abbas in the chat. In the different study settings, what proportion of under 2-year-old children are covered by electronic immunization registries and caregivers, parents that can be reached through mobile phone messages or reminders on childhood immunization schedules? So maybe I'll invite Sokyung, if you saw any evidence of that in your systematic review, and then over to other speakers.
So far, I haven't seen any the paper that has included the mobile, the electronic immunization registry or caregivers. So, anyone else who is familiar with this study settings?
I wish, Kaja, in the settings where we work, hard to even keep the cards in order and make sure they're in order. I wish is I think the short answer for some of the contexts where I'm working and where our teams are working. But it is an area to really explore because some of the work done in this area is quite fascinating. It's overwhelming, all of the work done in electronic records, but I have seen some examples of amazing things that can be done for a discrete question like this. And yes, why not electronic immunization records on mobile phones? I would love it.
Great. Are there any other final burning questions? Okay. Well, I think
Maybe
we are.
just
Go ahead,
to
Peter,
add
please.
to add to what Kevin said, leave alone just the practicalities of having the mobile devices being used for data collection and monitoring, and some of the areas that we work in, it's just almost impossible even to hold or to be seen with a handheld device because of security operations, security reasons. And it's like a risk if you are found to be carrying a mobile device. You could be picked out to be a spy or an agency, something like that. So it's just very difficult in some of our areas that we operate in. Yeah, just to give that perspective. Thank you.
Yeah, very important. Thanks for adding that perspective, Peter. So I really want to, I think we're at time. I want to thank our distinguished speakers for their insights and really all of you for coming to participate today in the rich discussion. And we'll be following up to share the recording with you all. So thanks so much, everyone, and have a great rest of your day. Bye-bye.
Thanks for
Thank you.
joining,
Bye.
everybody.
And thanks
All
for
the
your
best.
moderating.
Thanks.
Happy
Yes,
to.
of course.